Right, diving right in today. The 2024 consensus on CPR. We're going deep. You've sent some fascinating articles and research. Really excited to get your insights on what's new and especially what it all means for anyone who might have to do CPR, in a real-life situation.
Yeah, no, absolutely. It is a fascinating area, always evolving, lots of research going on. And you're right, the key is to distill all this information into something practical, something that people can actually use when those critical moments happen.
Right, absolutely. So let's start with the basics. Let's picture this. Someone's collapsed, not responsive. You've called 911, checked for breathing, nothing.
hmm
What stands out in the 2024 consensus? Like, what's the first thing that jumps out?
The emphasis really hammering home the importance of high-quality chest compressions. That's always been the foundation, of course. But the 2024 update really stresses minimizing interruptions, making sure the depth and rate are spot on. We're talking at least 2 inches deep for adults at a rate of 100 to 120 compressions a minute.
So it's about that constant pumping action, keeping the blood flowing to the heart and brain, minimizing interruptions. That means switching rescuers quickly, avoiding any pauses, right?
Precisely. Every second counts during a cardiac arrest. Got to maintain that continuous flow of blood. And speaking of flow, the surface you do CPR on, it matters. It really does.
That was one of the things that really got my attention. I hadn't really considered the surface and how much that could actually impact how effective the compressions are.
Yeah, it's fascinating, really. Research shows a firm surface is ideal, like a floor or a backboard. Provides the right resistance for those compressions, for them to really be effective. But of course, you don't always have those ideal conditions, do you?
Right, right. What if you find yourself needing to perform CPR on, say, a softer surface, like a bed?
They address that specifically, actually, the 2024 consensus, emphasizing the need to minimize mattress compression. So you'd put a firm object under the patient, like a backboard. Make sure the force of those compressions goes into the chest, not absorbed by the mattress, right?
So it's all about maximizing that force, keeping that circulation going. And along with the chest compressions, there's defibrillation.
Absolutely. Early defibrillation, that's key, especially for shockable rhythms like VFib, pulseless VTach. Those are the situations where the AED, the automated external defibrillator, can deliver that electrical shock. Try to restore a normal heart rhythm.
So in those situations, the AED takes priority over the chest compressions.
If it's immediately available, then yes, absolutely, use it. ASAP. But if you're alone and you need to go get it, start CPR while someone else retrieves the AED. Those high-quality compressions, they buy you time, increase those chances of survival.
So acting quickly, decisively. Now, what about those non-shockable rhythms, PEA, asystole? The AED, it's not effective in those situations, right?
That's right. With PEA and asystole, the focus shifts. High-quality CPR. Identifying and treating any reversible causes. And that's where those H's and T's come in.
The H's and T's. A lot to remember when you're in that high-pressure situation. Is there a way to kind of break those down into, like, more manageable categories?
Definitely. Think of it as addressing the underlying reasons the heart might have stopped. So H's, hypovolemia, severe blood loss, hypoxia, low oxygen, hydrogen ion, acidosis, hyperkalemia, electrolyte imbalances, hypothermia. Then you've got your T's. Tension pneumothorax, collapsed lung pushing on the heart, tamponade, fluid buildup around the heart, toxins, like a drug overdose, and thrombosis, blockages in the blood vessels.
It's almost like a checklist.
Yeah.
Running through those H's and T's, see if there's anything you can address right away, give the patient the best chance.
Exactly. And alongside those H's and T's, you've got medications like epinephrine and amiodarone.
Yes. Epinephrine a cornerstone of cardiac arrest management, right? Helping improve blood flow to the heart and brain.
Great.
Constricting blood vessels, increasing the heart rate.
That's right.
And amiodarone, that's an antiarrhythmic drug. What is that typically used?
Amiodarone, primarily for those shockable rhythms, especially if they're refractory to those initial defibrillation attempts. So if the rhythm keeps coming back after being shocked, amiodarone can help to suppress those abnormal electrical impulses.
So epinephrine for all cardiac arrests, amiodarone specifically for those stubborn, shockable rhythms. What about the dosage for those medications?
Epinephrine, the 2024 consensus recommends 1 milligram, IV or IO, every 3 to 5 minutes. And for amiodarone, the initial dose is 300 milligrams, IV or IO, followed by a 150 milligram dose if needed.
It is a lot to take in, but having a clear understanding of these guidelines, these dosages, could really make all the difference in that cardiac arrest situation.
Absolutely. Knowledge is power, especially when it comes to saving lives. Now, moving beyond that initial response, the 2024 consensus also gets into post-arrest care, which is just as crucial for optimizing recovery, minimizing those complications.
That's a whole other area with its own set of intricacies. And I know there are some interesting updates in the 2024 guidelines when it comes to post-arrest care. Let's explore those further.
Yeah, post-arrest care is all about, giving that patient the best possible chance for a good recovery. And one of the areas that's really seen significant updates is oxygenation and ventilation after a cardiac arrest.
That's interesting because I remember like back in the day, it was always like 100% oxygen right away, boost those oxygen levels as quickly as possible,
Right, that was the thinking before, but more recent research has kind of shown that both too little and too much oxygen can actually be harmful.
Oh, wow. Okay, so what's the approach now?
The 2024 consensus recommends starting with 100% oxygen initially, but then adjusting it. To maintain an oxygen saturation between 94 and 98%, it's all about finding that sweet spot, enough oxygen, but not too much.
So it's more of a personalized approach now, tailoring those oxygen levels to each patient's, specific needs.
Exactly. And the same goes for ventilation, the rate and depth of breaths. The goal is to avoid both underventilation and overventilation. The guidelines suggest aiming for, a normal partial pressure of carbon dioxide, which basically reflects how well that ventilation's working.
So we're monitoring both the oxygen saturation and the carbon dioxide levels to fine-tune those ventilation settings.
Precisely. And speaking of fine-tuning, another really critical aspect of post-arrest care, blood pressure management.
I imagine there are specific targets you're aiming for there with blood pressure.
Well, it's not quite as simple as that. The 2024 consensus suggests maintaining a mean arterial pressure of at least 60 to 65 millimeters of mercury. But they acknowledge that, the optimal target, it can vary from patient to patient.
So it's about ensuring adequate blood flow to those vital organs, but understanding that individual patient factors might require adjustments to that target.
Exactly. And research is ongoing to determine, if specific blood pressure targets are better for certain groups, like patients with pre-existing hypertension or other health conditions.
It seems like personalization is a key theme here in post-arrest care, moving away from rigid protocols towards a more tailored approach.
Absolutely. And that's reflected in the guidelines for temperature control as well. The 2024 consensus continues to recommend actively preventing fever, targeting a temperature of 37.5 degrees Celsius or lower.
I remember learning about therapeutic hypothermia. Cooling the patient down to protect the brain after a cardiac arrest. Is that still the standard practice?
It is still recommended, yes. But the guidelines acknowledge that there's some uncertainty about whether all patients benefit from targeting a specific hyperthermic temperature,
So preventing fever is crucial. But the precise target temperature for cooling might depend on the patient and the situation.
That's right. And that brings us to another important topic in post-arrest care, seizure management.
Right. Seizures can definitely complicate the recovery process. What do the guidelines say about managing those?
Interestingly, they advise against using anti-seizure medication as a preventative measure. The research hasn't shown a clear benefit to that approach. However, if a seizure does occur, they recommend treating it promptly.
So it's about responding to seizures if they happen, but not trying to prevent them with medication, unless there's a specific reason.
Exactly. And research is ongoing to determine the best ways to both prevent and treat seizures in patients who've had a cardiac arrest.
Now, we've talked about oxygen, blood pressure, temperature, seizures. What about those really challenging cases where traditional CPR just isn't enough? What options are there?
Well, in those situations, we might consider something called extracorporeal CPR, or ECPR.
ECPR. That sounds incredibly advanced. What exactly does it involve?
Essentially, it's using a machine to circulate and oxygenate the blood. Think of it as an external heart-lung machine. Gives the body a chance to recover while the machine's doing the work. It can be a lifeline. In cases where conventional CPR isn't restoring a pulse.
So it's like a temporary support system, allowing the heart and lungs to rest and potentially recover.
That's a good way to put it. Yeah. ECPR is a complex procedure, though. Requires specialized equipment, expertise, not something that's available everywhere, but it can be incredibly valuable in those really dire situations.
Are there specific guidelines on when ECPR should be considered?
The 2024 consensus recognizes ECPR as a promising therapy, but emphasizes that research is ongoing to identify which patients benefit the most and when it's most effective. It's a rapidly evolving area. We're learning more all the time about how to utilize this technology to save lives.
That makes sense. Now, shifting gears a bit, the 2024 consensus also addresses the specific considerations for managing cardiac arrest during pregnancy.
Right. That's an incredibly important area. The guidelines really emphasize the importance of immediate action and recommend a cesarean section if the pregnant individual doesn't respond to those initial resuscitation efforts.
It sounds like the priority is delivering the baby quickly to give both the mother and the baby the best chance of survival.
Exactly. In these situations, time is of the essence, and prompt action can make all the difference.
Now, so far, we've been focusing on adult cardiac arrest, but the 2024 consensus also has detailed guidelines for pediatric and neonatal resuscitation. Those are situations that require a whole other set of skills and considerations.
Absolutely. Managing cardiac arrest in children and infants, it presents unique challenges. It requires specialized knowledge.
Let's delve into those pediatric and neonatal guidelines next. There's a lot to unpack there. I'm eager to hear your insights on the latest recommendations for these vulnerable populations. So when it comes to pediatric cardiac arrest, what are some of the key updates in the 2024 consensus? What really stands out?
One of the biggest changes is in how we manage the airway. In those out-of-hospital settings, the guidelines now recommend bag mask ventilation over intubation or supraglottic airways.
That's interesting. I always thought intubation was considered the gold standard for airway management during a cardiac arrest. Why the shift away from that, especially in those critical moments?
Yeah, the main reason is to minimize interruptions in those chest compressions. Intubation, even for, experienced providers, can take time, disrupt that flow of CPR. Bag mask ventilation, while maybe not as secure as intubation, it can still provide effective ventilation while allowing those compressions to continue uninterrupted.
So it's about that balance, right? A secure airway versus continuous compressions. And this is specifically for out-of-hospital situations, right?
Exactly. In the hospital, you've got more resources, specialists. The decision to intubate would be made based on, the individual child, the situation, things like the child's age, the underlying cause of the arrest, the team's experience, all those factors.
It makes sense to tailor the approach to the specific circumstances. Now, what about ventilation rates in pediatric CPR? Any new insights there?
There's been a lot of discussion about optimal ventilation rates. The 2024 consensus acknowledges this ongoing debate, but suggests using rates closer to age-appropriate respiratory rates.
So rather than a one-size-fits-all approach, we're adjusting that ventilation rate based on the child's age, how they normally breathe.
Precisely. Individualizing care, even in these emergency situations. And like many aspects of CPR, more research is being done to figure out the best ventilation strategies for pediatric cardiac arrest.
It's good to know that those guidelines are constantly evolving based on the latest science.
Yeah.
Now, are there any specific conditions in children that that the 2024 consensus kind of highlights as requiring a specialized approach?
One that's particularly challenging, cardiac arrest in a child with pre-existing pulmonary hypertension. The guidelines really stress the importance of, recognizing and managing a pulmonary hypertensive crisis quickly, which can make resuscitation much more difficult.
Pulmonary hypertension, high blood pressure in the arteries of the lungs can really complicate things, during a cardiac arrest.
It can, yeah. Makes it very difficult to achieve effective ventilation and circulation. The guidelines suggest, optimizing those ventilation strategies, possibly even using therapies that target pulmonary hypertension to improve outcomes in these kids.
So it's a more specialized approach, requiring a deeper understanding of how pulmonary hypertension affects the body.
Especially during a cardiac arrest.
Exactly. It highlights the importance of specialized training for those who care for children in these situations, these critical situations.
Now, before we wrap up, we need to talk about the tiniest patients, newborns. The Neonatal Life Support guidelines also have some noteworthy updates. One that's particularly interesting involves umbilical cord management in premature infants. The 2024 consensus recommends delayed cord clamping, or cord milking, over immediate clamping.
I've heard about delayed cord clamping. The idea is to allow more blood to transfer from the placenta to the baby.
That's right. This extra blood, it can make a big difference for these fragile infants, improving their circulation. reducing the need for blood transfusions.
And cord milking, what does that involve exactly?
It's basically gently squeezing the umbilical cord to, push more blood toward the baby, achieves a similar effect to delayed clamping, optimizing the baby's blood volume from the very beginning.
Interesting. Amazing how these seemingly small changes can have such a big impact. Any other notable updates in neonatal resuscitation?
The guidelines also address the use of therapeutic hypothermia for newborns who've experienced moderate or severe hypoxic ischemic encephalopathy, or HIA.
i.e., brain injury caused by a lack of oxygen. That's a serious condition. How does therapeutic hypothermia help?
By carefully cooling the infant's body temperature, we can help protect the brain and potentially, improve those long-term neurological outcomes.
Similar to therapeutic hypothermia in adults after cardiac arrest, but adapted for those unique needs of newborns.
Precisely. And as with any medical intervention, especially in such fragile patients, the decision to use therapeutic hypothermia is made on a case-by-case basis, weighing the potential benefits against any risks.
It's incredible to see how much effort and research goes into improving, every aspect of resuscitation, from that initial response to the long road to recovery.
It really is. It really is. And it reflects the unwavering commitment of healthcare professionals worldwide to saving lives and giving everyone, regardless of age, the best possible chance, a positive outcome.
So wrapping it all up, the 2024 International Consensus on CPR offers a wealth of valuable insights. Whether you're a seasoned healthcare provider or someone who just wants to be prepared, these guidelines provide the latest evidence to empower you to act effectively in those critical moments.
It's about equipping everyone to be a link in that chain of survival.
And the learning doesn't stop here. I encourage everyone to explore the full 2024 consensus document. There's so much valuable information there.
Absolutely. Because when it comes to cardiac arrest, knowledge is power. The power to potentially save a life.
That's it for our deep dive into the latest CPR guidelines. Thanks for joining us. And stay tuned for more insightful explorations of the latest advancements in healthcare.